I am Sana Al-Khatib. I am an electrophysiologist at Duke University, and it is my pleasure today to interview my friend and colleague, Dr. Greg Marcus, who is the principal investigator of the Holiday trial that was presented at the ACC 2021 meeting.
Thank you so much, Sana. It's a pleasure to chat with you about our study.
Let me first of all congratulate you on completing this trial, and I'd like to ask you the first question regarding what prompted you to think of designing such a trial.
We were largely motivated by this discrepancy between our clinical experience and the current available literature on alcohol and AFib, where there's now quite compelling and consistent evidence that chronic alcohol consumption appears to be a risk factor for the development of AFib, and yet our patients have been telling us that acutely ingesting alcohol seems to be an important trigger for their atrial fibrillation episode, and it's clear that understanding the determinants of discrete atrial fibrillation episode is often top of mind for our patients. The other limitation of past investigations into the relationship between alcohol and AFib is that they all tend to rely on self-report of alcohol consumption, which may not be reliable. And so we sought to leverage really mobile technology in the hopes of objectively ascertaining alcohol consumption and then looking at these temporal relationships in the immediate sense among ambulatory individuals to see if alcohol consumption was acutely associated with discrete atrial fibrillation events.
Can you tell us more about the patient population that you targeted and then how the follow-up took place?
We enrolled paroxysmal atrial fibrillation patients predominantly presenting to our electrophysiology practice at UCSF. We made sure first that there was no evidence of any history of alcohol use disorder. We used a validated questionnaire called the Audit C questionnaire in the hopes of excluding those who may have demonstrated some problems with substance use or alcohol abuse. We also didn't include people who abstained from alcohol. So we just took people who had documented paroxysmal atrial fibrillation and consumed at least one alcoholic drink a month. So they didn't have to drink a lot. The other important thing was they couldn't be planning to change their treatment for their AFib in the next month or so. And that made it a bit challenging, especially because most of these patients coming to an EP practice are getting started on an antiarrhythmic or getting scheduled for an ablation, although sometimes those ablations were scheduled a few months out, which gave us a good opportunity. We then fit them with a continuously recording ECG device. Initially, this was the LifeWatch ACT device in the first 27. The remainder, 73 individuals, received 2 successive Zeo patches, so monitoring for about a month. We instructed them to press the button on the Zeo patch or press the patient-activated button on the cell phone that accompanies the LifeWatch device whenever they took or consumed one standard drink. And we explained to them by a standard drink, we mean a glass of wine, a 12-ounce can or bottle of beer, or a shot of hard liquor. We then also fit them with an ankle transdermal alcohol sensor called a SCRAM device. That's the company's name. We recognize that stigma could be an issue, that people may be embarrassed walking around with this ankle device on. So to try to mitigate that, we put a big UCSF cardiology sticker on there, which did seem to help. Then we saw them back at 2 weeks and then again at 4 weeks, where we interviewed them, made sure the devices were working, refit them with another Zeo patch, made sure they were following their instructions. And at each of those 2-week visits, we got a finger stick test for this compound called phosphatidylethanol. Some people refer to it as PEth. And PEth is kind of like a hemoglobin A1C for alcohol consumption. So it reflects the amount of alcohol consumed in the past 21 days. The intent there was to essentially validate or corroborate the patient at the real-time button presses that the participants were doing, recognizing that the alcohol sensor would also provide objective evidence of alcohol consumption. And I'll finally say that the hope was that by having patients press that button in real time, there could be no recall bias.
So how many patients did you end up enrolling, and can you actually share the results with us?
Based on our power calculations, which were quite conservative, we estimated we would need about 100 patients to detect significant results. And we were able to achieve that number. Of those, during the monitoring period, 56 exhibited at least one atrial fibrillation episode. We then performed a case crossover analysis where essentially each participant served as both cases and controls. This hopefully should address confounding at least between individuals. And in brief, we found that when one pressed the button once, there was an approximate twofold greater odds that was highly statistically significant of an AFib event occurring in the following 4 hours. If they pressed that button twice, meaning they had more than one alcoholic drink, that was associated with about 3.5-fold greater odds of a discrete atrial fibrillation event within the next 4 hours. Separately, when we looked at the alcohol exposure as determined by the transdermal ethanol sensor, there also were significant relationships. So the peak alcohol observed was associated with a higher risk of AFib, and similarly, simply the area under the curve of the alcohol exposure that was detected was also associated with near-term atrial fibrillation events.
As we both know, there have been several studies looking at this question of how AFib is associated with alcohol consumption, and it looks like your data are highly suggestive that there is a strong association between the two. Or would you consider your results confirmatory? And if not, what are the next steps that need to be taken?
The novelty of the current study that adds to what we think we already know is this acute relationship. So previously, epidemiologic studies and now one really important randomized trial demonstrate that chronic alcohol consumption is associated with AFib. The more one drinks, the higher the risk of AFib. But this sort of closely knit temporal relationship where a drinking event is associated with a discrete particular AFib episode has been really difficult to prove. Patients have told us that this occurs, but one of the issues is that alcohol is so ubiquitous, there could be something called an immediacy heuristic, where one just attributes some outcome, such as AFib, to something that just recently happened. So these data now demonstrate that not only is there a chronic relationship where those who tend to drink more over many years or months experience a higher risk or burden of AFib, but rather that within a matter of hours, when one consumes alcohol, there's a heightened risk of an actual atrial fibrillation event occurring. The other thing that this tells us in terms of a broader extrapolation is that when an AFib event occurs, it's not completely random. It's not just chance alone. There are determining factors to when that atrial fibrillation occurred right then and there, which then opens up the possibility and perhaps a new field of investigation to really try to hone in on what are the various factors that determine the exact timing of the initiation of a discrete atrial fibrillation event.
In terms of a take-home message based on these results, what would you share with the audience?
One important limitation that's relevant to that is that these were patients who already carried a diagnosis of atrial fibrillation. So it's difficult to extrapolate this to the general population. And in fact, this is why studying alcohol is so interesting. Almost certainly there are heterogeneous effects. There may be, based purely on observational data, some beneficial effects to moderate alcohol consumption or perhaps a drink a day. At the same time here in the current study, we found that even one drink among these individuals who already had AFib could increase the risk that an AFib event could occur. So I think in terms of take-home messages, among those with atrial fibrillation, those that are interested in doing everything they can, everything under their own power, to minimize the chance an AFib event will occur. These data demonstrate that alcohol abstinence or minimizing alcohol is important and is something they themselves can do that they have under their own control to affect or influence the risk an AFib event can occur. More broadly speaking, these data suggest, again, that the likelihood an AFib event occurs is not purely based on random chance, that there are exposures, influences, perhaps many under the direct control of patients themselves, if we can figure out what those are, that may ultimately be important in staving off a discrete atrial fibrillation event.
Congratulations again on the completion of this very interesting trial. I really look forward to see it in print.
Great. Thank you so much for the opportunity. Appreciate it.